Our project is the pharmacogenomic implementation plan for CYP2C19 genetic testing prior to initiation of citalopram. So citalopram is a selective serotonin reuptake inhibitor used commonly for major depressive disorder and for anxiety. So just some background about the gene CYP2C19. CYP2C19 is implicated in many SSRIs, and we picked this gene because this genetic variations in CYP2C19 can lead to adverse effects when started on citalopram, and also it can lead to decreased efficacy. So CYP2C19 pharmacogenomic testing for patients being started on citalopram will be first started in the psychiatric clinics within the University of Kansas Health System because we want to first see how the effects of implementation will be on the general population there. And then one of the main side effects that we're concerned about is QT prolongation, which is a dangerous cardiac arrhythmia. And the purpose of this document is to provide a brief overview of the CYP2C19 and citalopram pharmacogenomic implementation plan within the University of Kansas Health System. So as for evidence, citalopram and the CYP2C19 gene are supported by PharmGKB evidence, and PharmGKB rates this drug gene pair level 1A, which is the highest level of evidence. The effect of CYP2C19 polymorphisms on the clinical response of citalopram is also supported by CPIC guidelines. So for the CPIC guidelines, individuals who are CYP2C19 ultra-rapid metabolizers, most commonly the star 7 diplotype, they're at an increased risk of treatment failure with citalopram. This is because citalopram is composed of a racemic mixture of R-citalopram and S-citalopram, with S-citalopram being the active form of citalopram. And with the CYP2C19 polymorphisms, it can cause that citalopram to be more rapidly metabolized into its inactive form. For these patients, they will experience poor response to being started on citalopram. On the other hand, individuals that are poor metabolizers, most commonly CYP2C19 star 2 diplotype, star 3, or star 3, they have an increased risk of side effects from citalopram because they are metabolizing the active form into the inactive form as rapidly, which can lead to a buildup of the S-citalopram. And as mentioned earlier, the most dangerous side effects is QT prolongation.
To meet the growing demand for genetic testing, the University of Kansas Health System should invest in the implementation of an in-house CLIA-certified genetic testing lab. Due to the size of the health system and the projected increase in use, this recommendation was made to ensure that patients would be receiving timely and accurate lab results so that they could sooner initiate informed pharmacotherapy. And upon receiving their results, patients would have the opportunity to consent to the results being sent to genetic testing registries.
So regarding reimbursement, initially the pharmacogenomic testing for CYP2C19 will be ordered from an outpatient or clinic setting, so from that psychiatric clinic setting, and then the cost will be reimbursed through commercial insurance. Most commercial insurance programs, including Blue Cross Blue Shield, cover medically necessary CYP2C19 genetic testing, but with varying copays. On the other hand, CMS also covers some genetic testing, including CYP2C19, prior to initiating citalopram. With both of these, with both commercial insurance and CMS, they both require documentation supporting the medical necessity of that genetic testing. So to support the medical necessity portion, we would need to include the ICD-10 codes. And if the patient's insurance doesn't cover CYP2C19 testing, we still want to be able to provide that patient with the opportunity to get tested to make sure that they're not at an increased risk of side effects or at an increased risk of poor efficacy. To do this, the hospital system will offer a discounted rate and charge a maximum of $150 per genetic test. And on top of that, we will be offering financial assistance programs to help patients better afford this test.
So, in order to create a system to improve patient care and safety, the pharmacy team would work with IT to design a clinical decision support that fires if a provider attempts to initiate citalopram for a patient or would change the citalopram dose for the patient. And it would also provide recommendations for genetic testing or dosing and medication information per the CYP2C19 genotype. The alerts might appear as low risk, medium risk, or high risk, and the risk would be determined and stratified by the patient's risk factors for QT prolongation. The displayed CDS alert would be CYP2C19 genetic status, may be predictive of an adverse reaction or a poor response to citalopram. If no genetic information is on file, the alert would include CYP2C19 genotype information does not appear to be available for this patient. Please consult a clinical pharmacist for more information. If the information for the patient is available, the CDS recommendations would be displayed for the medication and the dose that it would recommend. After viewing the alert and the patient's risk factors, the physician may accept the CMS recommendation and order genetic testing or override the alert and continue to prescribe as they see fit.
For program evaluation and quality improvement, we will be recording several different parameters throughout the first year of implementation to establish that our program is working and that it is effective and helping to improve patient outcomes. So we have a few key performance indicators and outcome indicators that we will be using to evaluate the implementation process. Key performance indicators we will be evaluating include percentage of new patients prescribed citalopram that were tested, number of tests run, test turnaround time, CDS firing times, percentage of physicians following CDS recommendations, physicians' acknowledgement if rejecting CDS, patient acceptance of CYP2C19 testing, percentage of tests covered by insurance, and reimbursement rates. The pertinent outcome indicators that we are using to prove efficacy of our program are reduction in treatment-related side effects, reduction in hospital and ER visits due to treatment side effects, and a reduction in treatment failure. Physician and patient education will be performed both before and throughout the process. Physician education will begin with an initial evaluation to assess physicians' overall knowledge of pharmacogenomics. If physicians are found to have minimal exposure, they will be required to attend both a short in-person and online education session, and that will be provided to review the basics of pharmacogenomic principles. Training sessions will begin with pharmacogenomic principles, and then we'll move into the more specific information relevant for our gene-drug pair, citalopram and CYP2C19. Last, case examples will be given to physicians so that they can see what they might encounter in practice. There will be a pharmacogenomic expert on hand at the training and will be available via a hotline that is provided in the CDS. So patient education will follow a 2-visit model. They will have an initial visit before testing that will provide basic information about the testing along with the relevance to their treatment. This will include an outline of the benefits, risks, and limitations of the genetic testing. Patients will complete a pretest to gauge patient knowledge, and then will watch a video with their physician and given more information based on how they scored with their knowledge and more questions that they have. So at this visit, we will also obtain written consent from the patient to undergo genetic testing and allow their records to be used in our program evaluation and quality improvement. And then they will also be given an infographic that explains a little more about pharmacogenomics they can refer to at home. The second visit will occur after genetic test results are received, and the physician and pharmacist will go over the results with the patient and discuss what that means based on their treatment options. This is the infographic that we will be giving to the patient. It just gives brief genetic testing information, such as the US FDA found that 9 out of 10 people have at least one pharmacogenetic variation that could require medication adjustment. Brief information on pharmacogenomic testing, such as DNA containing genes, and this is what can affect how our body reacts to medications. And through genetic testing, we can analyze these genes and predict how the medications will work. It gives brief information on genetic variants and then gives brief overview on how it's an easy, non-invasive test that the patient can do outpatient setting for low to minimal cost, usually with commercial insurance. This is an example case showing how you would use our implementation using an example patient, their genotype, coming back from test results and how these results would affect their treatment.